Good evening to our East Coast participants and good afternoon to our West Coast attendees. We are thinking of all of you on California and Portland who might be impacted by the fires. Our hearts are with you. It is wonderful to have hundreds of you from across the country with us to discuss this important topic. Welcome to our webinar, Health Disparities in Prostate Cancer for Black Men, which is brought to you by Zero, the End of Prostate Cancer, in partnership with Dendreon. I'm Colony Brown, Senior Vice President of Marketing and Communications at Zero, and I'll be your host. Thank you all again for joining us today. Before we start, just a few quick housekeeping items. First, today's webinar is being recorded and will be posted on our website, zerocancer.org, later this week. Tomorrow, you'll receive an email with a link to the recording and a survey to share your feedback. In addition, and this might have been a little bit of our delay, we are live streaming on our Zero Facebook page and website. So welcome to all of our Facebook viewers as well. For those of you who may not already be familiar with Zero, the End of Prostate Cancer, we are the leading national nonprofit with a mission to end prostate cancer. Zero advances research, improves the lives of men and families, and inspires action. We're building Generation Zero, the first generation of men from prostate cancer. We have lots of activities for all of you to get involved with. Our National Run Walk series, which is now virtual and has events every weekend during the month of September. Also through programs like tonight, education and patient support programs, and grassroots advocacy. If you are new to the Zero community, we welcome you. I want to thank Dr. Kelvin Moses and Robert Ginyard, our two featured speakers, for sharing their time and expertise with us for this webinar. And of course, I also want to thank today's program sponsor, Dendreon, for their support. Here is a quick overview of what to expect for the next hour. After I make introductions, Dr. Moses will present on health disparities in prostate cancer and the promise of immunotherapy for Black men. Next, we'll have an opportunity to ask questions before handing it over to Robert Ginyard to share his experience as a patient and survivor. We'll conclude our webinar with an opportunity to ask some final questions, and then I'll close by sharing information about Zero's free patient support programs. To make this next hour as interactive as possible, I encourage all of you to ask some questions. We want to hear from you. You can ask your questions by typing in the Q&A box, which is located at the bottom of your screen. You can ask a question at any time, and we'll get to them at the end of each presenter's remarks. I'll do my best to help answer as many of your questions as time allows. Okay, let's get started with a few introductions. First, it is my pleasure to introduce Dr. Kelvin Moses. Dr. Moses is an associate professor of urological surgery at Vanderbilt University Medical Center, and he's the director of the Comprehensive Prostate Cancer Clinic. His work focuses on addressing health disparities in urological cancers, determining the role of patient health literacy within the healthcare system, and optimal care for patients with metastatic or castrate-resistant prostate cancer. Dr. Moses sits on Zero's Medical Advisory Board and Zero's Board of Directors. What you may not know about Dr. Moses is that he is also the proud father of Miles, his new son that was just born last month. So I was hoping we might get a glimpse of Miles, but I understand it might be his nap time, but he does always steal the screen when he's on with us. Our next speaker is Robert Ginyard. Robert, the dear friend, is a prostate cancer survivor and the chairman of Zero's Board of Directors. Robert lives in Baltimore, Maryland, and is an entrepreneur, former banker, marketing director, and podcast host. Robert is a veteran Zero champion who is tireless in his efforts to promote prostate cancer awareness and lift up others. He does this best as the founder of Dibby Dibby, dream it, believe it, do it, be it, which inspires us to live life to the fullest. Robert's also a family man and the proud father of two adorable daughters. Both of our speakers today are deeply committed to eliminating the health disparities in prostate cancer for Black men and are using their experience, knowledge, and voices to help lead Zero's new task force dedicated to addressing these critical issues. The goal of our Disparities Task Force is to help Zero strengthen existing initiatives, identify barriers, and design solutions to provide equal access to quality prostate cancer education, screening, and care for all men. We recognize that only when we zero out health disparities can we achieve our mission to end prostate cancer. As Dr. Moses will share, the statistics for Black men and prostate cancer are alarming. And unfortunately, so are the statistics for African Americans who are disproportionately suffering the impacts of the COVID-19 pandemic. To help us uncover some of these reasons behind these disparities and what can be done to close these gaps, I'll now turn it over to Dr. Moses. Thanks, Dr. Moses, for joining us. You have the floor.
Thank you very much. I hope I'm controlling the screen here. There we go. So this is my talk, Health Disparities in Prostate Cancer for Black Men. And in this, we'll review some of the data about, or the statistics about Black men, a little bit about how COVID-19 may be impacting this, and then some promises for future therapeutics. These are my current disclosures. So I said we'll review some basic prostate cancer facts. We'll introduce the prostate cancer disparity in Black men, discuss the impact of COVID-19 in Blacks and cancer diagnosis, and then summarize new findings in immunotherapy for Black men with advanced prostate cancer. So as a bit of background, in 2020, we expect over 191,000 new diagnoses of prostate cancer in the United States. And as you can see on the graph on the left, there has been a steady decline, particularly since the late 2000s. Fortunately, death had been declining over the last several decades in what is called the PSA era. Unfortunately, more recently, we're actually seeing an increase in mortality. And what the data has shown over and over again is that Black men have about twice the incidence of prostate cancer compared to white men, and have over 2.5 times the risk of death from prostate cancer compared to white men. Now, there's several factors that have an impact on how people will deal with prostate cancer. And a lot of times the focus is on genetic causes or biology. But in reality, the majority of what impacts prostate cancer survival are what are called social and economic factors. And this plays into what is known as the social determinants of health, meaning that things like your insurance status, your zip code, your access to care, the race of your treating physician, your environment, all of these play a significant role in how you will be able to survive prostate cancer. And one important thing to understand is that race is not a medical identity. You cannot test someone's genes and determine if they are Black or white or whatever. And essentially, race is a social construct, meaning it is set up in a way for a society to define people as they wish. It does act for a surrogate for socioeconomic status, geographic origin, and culture. However, searching for a single gene for every disease disparity, of which there are dozens, really diverts attention from the true cause. So in the instance of disease like sickle cell and cystic fibrosis, those are geographically endemic diseases that have a clear genetic cause. However, things like prostate cancer, breast cancer, diabetes, these are all multifactorial. And so if you're going to say that there's a genetic reason for the disparity in prostate cancer and everything else, you have to conclude that underrepresented populations who are experiencing these disparities are genetically inferior, which we know is not true. Therefore, we have to focus on why the disparity exists. So as I said before, SEER data has shown that Black men have over twice the risk of death from prostate cancer compared to white men. At diagnosis, Black men tend to have a higher stage and grade, however, are less likely to receive surgery versus radiation or receive any treatment overall. In fact, some studies that came out in 2011 showed that Black men are less likely to receive prostate screening for prostate cancer. And research that I and other groups have done have shown that Black men are much more likely to receive radiation or even non-treatment versus surgery for a stage-specific disease. In a broader context, it really shows that this is much more of a societal issue than just one race versus another. We've shown that Hispanics are now having an emergent disparity in prostate cancer outcomes as well as other cancers. And this will only be exacerbated as the Hispanic population grows. Native American and Alaska Native populations also have very bad outcomes from cancer, including a high mortality incidence ratio for almost every cancer except for liver cancer. And this is most pronounced in cervical, breast, prostate, and colorectal cancers, all of which are screen detected cancers. So there's really no reason why, if there is a affordable, widely available screening modality, that they would have such bad outcomes. Additionally, LGBT patients experience disparate rates of breast cancer and other diseases. Much of this can be traced to a fear of coming out to a physician, particularly if they're at a religious affiliated facility. There is pressure to conform to gender expectations. There is disregard for fertility for patients who do not express a binary disposition as far as gender or sexuality. And there's actually legalized discrimination against LGBT population. Here in my home state, unfortunately, there is a law that allows psychologists to refuse to see a gay or lesbian patient based on their religious views. So we've seen what in a chronic situation, how these disparities are negatively affecting African Americans. And we've seen really since February a very acute exacerbation of the disparities in this country in the form of coronavirus or COVID-19. And the data here is stark as well. Overall, 1 in 3 people who become sick enough to require hospitalization from COVID-19 are African American. That's 33%. In comparison to the fact that African Americans make up approximately 13% of the United States population. In New York, which had a terrible time with COVID-19, African American New Yorkers comprise 28% of deaths in New York City, 18% of deaths in New York State, despite being 22% and 9% respectively. In Louisiana, up to 70% of the deaths from coronavirus were African Americans, while only representing 32% of the population. Similarly, in Michigan, while African Americans make up 15% of the population of the state, 35% were represented with COVID-19, and African Americans accounted for 40% of deaths statewide in Michigan. And even in Chicago, African Americans represented 70% of the people who died from coronavirus. So what contributes to these disparities? And what it uncovers is that there's an underlying systemic racism that is built into the healthcare system, just like into every other system in this country, including education, law, medicine, and barriers to access with the known racial disparity of acknowledgement of symptoms and pain. Additionally, African Americans were a much higher likelihood of working what were termed essential jobs, and fewer than 20% of African American workers are actually able to work remotely. Additionally, African Americans are much more likely to live in a home with a larger number of persons or in high density areas such as cities. Lack of transportation or lack of medical facilities nearby is a huge contribution. And very importantly, what is the term called food deserts. So this is where there are specific areas within the country where there is no available fresh fruit, vegetables, or lean meats within a large enough radius where someone could travel to easily. So if people are not able to get adequate nutrition or eating processed foods, that can exacerbate chronic disability, which then if you place an acute issue like coronavirus on top of it can lead to death. Health disparities lead to worse health outcomes in hypertension, in diabetes, in asthma, and obesity. Environmental, educational, and employment discrimination are compounded by neighborhood redlining, meaning undervaluing of property and restriction of Black home ownership, as well as over-policing. Additionally, there was some early misinformation that somehow African Americans were immune to COVID-19 due to early statistics of where the disease was showing up. Now, during this pandemic, unfortunately, we've seen a decrease in the number of cancer diagnoses. As you can look from left to right, breast is in the first grouping. From baseline through March, April, you see a decline in the number of cancer diagnoses in breast, colorectal, and lung. And it's not that there are fewer cancers. In fact, it's more that patients were not coming in for routine testing, or if they had symptoms related to these organ systems, were ignoring them either out of fear for coming into the medical system or inability to access this. And this is placed in the backdrop of knowing that localized disease has been decreasing in incidence, and much of this is due to changes in PSA practice, but regional and distant disease, so meaning spread to lymph nodes or to bones or other organs, has actually been increasing over the last several years. And again, this has some reflection on changes in PSA screening patterns in the country. So knowing that there is a disparity in prostate cancer for Black men, and there's an increase in the number of men presenting with distant disease, we need to find some hope in therapies that are available for prostate cancer in Black men. And this is where immunotherapy comes into play. So I can go quickly through a scenario. Mr. S is a patient of mine, 61-year-old Black man who presented with metastatic castration-resistant prostate cancer. He had had surgery several years ago for high-grade disease and a positive margin. And his PSA, although initially undetectable, began to rise to 3.5, and he had negative staging imaging. He was on androgen deprivation with Lupron, and his PSA dropped again until it began to rise in April of 2014 when it was up to 5. As you can see here on his bone scan, he has a lesion in his spine. So now he is defined as metastatic castrate-resistant prostate cancer, which is called mCRPC. And if we look at the guidelines for men who had not had any chemotherapy before, there are several options. And for the remainder of this talk, we'll talk about Sipuleucel-T, which is a form of immunotherapy whose trade name is Provenge. Sipuleucel-T is FDA approved for men with asymptomatic metastatic castrate-resistant prostate cancer who have reasonable life expectancy. There are some side effects noted. Most men experience flu-like or if they get their flu shot, something like side effects from that, nausea, back pain, and hypertension. Very rarely is it associated with stroke or blood clots. The study that showed the efficacy of Sipuleucel-T came out in 2010. And here you see HR, that means hazard ratio, and that means the risk of death. And if it's less than 1, that means a reduced risk of death. So these men had a 22% reduction in the risk of death from prostate cancer if they received Sipuleucel-T, and about 4 months increased survival. Now, importantly, Sipuleucel-T does not have an impact on PSA or on radiographic imaging. So you're really basing the importance on it on its survival benefit. And what further studies have shown is that the lower the PSA, the better the benefit. So if you look here at the top line, baseline PSA less than 22, 22 to 5, sorry, 22 to 50, 50 to 134, greater than 134. You look at the bottom, again, that hazard ratio, if it's less than 1, means lower risk of death. And you can see here in the lowest quartile or quintile, with PSA of less than 22, they had a 49% reduction in death. In the next highest group, there's a 26% reduction in death, although that was not deemed significant. Now, that study was not designed to detect the difference between groups. However, the conclusion is that earlier treatment may have a better survival. So in order to understand how Sipuleucel-T has a benefit in what's called the real world or out in practice, there was something called the Prostate registry. So you had over 1,900 patients who received Sipuleucel-T from 2011 to 2013, and 12% were African American. So that mirrors the overall proportion of African Americans in the US population. And so that allowed for adequate comparison. And what it showed is that based on PSA numbers, if you see in the first column, PSA of less than 7.5, both African American men and white men had an improvement in survival, but African American men actually had 17 months greater survival compared to white men. And then at PSA of 7.5 to 26.8 in the second column, African American men had almost a 15-month improved survival compared to white men. So in summary, we've shown that prostate cancer is one of the most commonly diagnosed cancers in men and the second most common cause of cancer death. Black men have worse incidence and mortality from prostate cancer, and structural inequalities play a major role in determining this disparity. Unfortunately, COVID-19 has exacerbated cancer disparities and forced some to delay screening, diagnosis, and treatment. And lastly, we discussed that immunotherapy holds promise in reducing excess death from prostate cancer among Black men due to an improved response. Thank you for your attention to this portion of our presentation. I'll be happy to answer any questions.
Well, thank you very much, Dr. Moses. We certainly do have a few questions in the queue for you. And I think starting with a patient has asked, how do they learn more about immunotherapy? You know, what would you recommend to them?
So it really, you need to talk to your physician. So if you are in the setting of metastatic cancer, prostate cancer, you have several options for therapy. There's hormone therapy, there's chemotherapy, and there's immunotherapy. This is something you can discuss with some urologists do treat with Sipuleucel-T, such as myself, or a medical oncologist as well would have that information. Obviously, you can go online and do some research on your own. I would always caution people to use reputable websites, but there is information as well about immunotherapy, but certainly speak with your physician about if it's right for you and what could be the benefit.
And how recently has this immunotherapy treatment been available? It's relatively new?
So no, Sipuleucel-T was approved in 2010. So it's been around, and the trial was several years before that. So it's been around at least as an approved therapy for 10 years.
Thank you. And then we have Sanford here, who's asking, how significant is health literacy and health education towards addressing prostate cancer outcomes?
Very important. So research we've done here has shown that health literacy is associated with outcomes. And really what's important is that physicians need to recognize if a patient has decreased health literacy, and then to provide information that is appropriate for their level. You have to describe and discuss treatments in a way that's understandable. And for many of my patients, I'll draw a picture or draw a diagram in case they're a visual learner, or I'll provide some literature that's written at an appropriate level. But really, if someone does not have good health literacy and the physician does not speak with them on the appropriate level, it puts them at risk for making maybe bad health decisions because they don't have all the information or may not understand all the information. And that's really incumbent on physicians and practitioners to understand and provide appropriate information for patients so that they can make the best decisions for themselves.
Thank you for that. And then another question that came in was, what advice do you have for Black patients as they face these health disparities? How do you advise your patients to help overcome those? What is some of the specific tips or, ways that they can inform themselves?
So definitely educate yourself. So read as much information from reputable sources as you can. Make sure that the options, when you're given options, to ask, hey doc, are there any other options? Are there any other treatments that are new? Are there clinical trials? Is there anything else? If you can, I would say obtain a second opinion. I have had patients who see me as a second opinion, and I've had patients ask me if there's someone else they can see. And really, your physician should be very favorable for that because, again, it's all about gaining as much information as possible. And make sure that the physician takes their time to explain things. If you're feeling rushed or you have questions that are unanswered, you have to ask them. And I understand, especially when you're sitting in the doctor's office, even myself as a physician, you don't always bring things up or you might get intimidated. But really, it's about your health. And so you have to make sure that the physician takes the time, answers your questions, and then obtain second opinion if necessary to get as much information as possible.
Thank you. And then on one of your slides, I saw that you had some of the other cancers and the fact that the screening is being impacted by COVID. I wonder what you're seeing with these two things colliding, prostate cancer and COVID. Are you seeing that less people are being screened? What is your recommendation? It is Prostate Cancer Awareness Month this month. What are you telling folks that ask you about whether they should be screened?
So overall, like I said, we are seeing a decline in the number of cancers that are diagnosed, and screening across the board has declined over the last several months. So as a patient, you should contact your physician, make sure they have a plan for keeping you safe from coronavirus. So that means everybody's wearing a mask, there's social distancing, everybody's washing their hands or wearing gloves. And overall, we're seeing a decline in screening just because of the recommendations that came out several years ago from the United States Preventive Services Task Force. And so we're seeing it's compounded. So the decline in screening overall versus, and in addition to the acute decline in the last several months. So patients do need to get your colonoscopy, get your prostate screening done. If you're a smoker, you need to get your lung cancer screening done. All these things are very important that patients stay on top of this for their own health.
So you talked about a couple other cancers. We have a question here that's trying to better understand. Years ago, I was diagnosed and treated for testicular cancer. Do I have a greater chance of having prostate cancer?
I am not aware of any association of testis cancer and risk of prostate cancer. I don't know of an association. I haven't read any literature that says that someone's at increased risk. Depending on the treatment that they got for testis cancer, especially if they got chemotherapy, there is a slightly increased risk of lymphoma or leukemia blood cancers. But as far as prostate cancer, I don't think so. I don't know of any association.
Marty is asking, do we know why African American men get prostate cancer at a younger age?
Unclear. I have my hypotheses, but it is partially it is a disease of inflammation, and as Black men in this country, inflammation is a product of stress, and stress is a product of your environment. And so that is my suspicion. I don't have any data to prove that, although I'm working on that. It appears to be a new world phenomenon. So Black Caribbean men have higher incidence compared to white men. It's not as high as Black men in the United States. African men, particularly in West Africa, who live in rural areas and primarily vegetarian diet, actually have very low incidence of prostate cancer. So there is some environmental effect. There may be some dietary effect, and there's certainly an inflammatory, stress-related effect that could be causing that.
Thank you. And Howard is asking, are Black men with prostate cancer also overtreated?
Potentially. So if you are diagnosed with low risk prostate cancer, so that means Gleason score of 6 and PSA of less than 10, the majority of these men do not require treatment and can be on active surveillance. So Black men can be on active surveillance just like anybody else. And so that's the group where overtreatment is a problem. But overall, if you look at every risk category, every Gleason number, Black men are less likely to receive treatment compared to white men. So maybe, for the very low risk disease, that's fine. But for intermediate and high risk disease, that's deadly.
Yes, it certainly is. Carrie is asking about, are the disparities between African Americans and other groups more prevalent in certain geographic areas, for example, rural versus metropolitan areas?
Yes, so the disparities are greatest in the Southeast and on the West Coast as far as geography. As far as rural urban, I'm actually not recalling that. I know urban numbers are pretty dismal. And again, it's not even really distance to a medical center, it's whether or not you can get in the door. But there are definitely regional differences in outcomes.
Then we have a follow-up question here. Can you explain the difference between metastatic hormone-sensitive prostate cancer and castration-resistant? Can immunotherapy be used for hormone-sensitive?
So the difference is that's a patient who has metastatic disease that has spread to other areas. The hormone-sensitive means that they are getting androgen deprivation therapy, and it is suppressing their testosterone and suppressing their PSA. So that means that their PSA, it should be undetectable. Whereas castration resistant means that they have a low testosterone on androgen deprivation, and despite that, the PSA is increasing. So that means they're resistant to a low testosterone. Sipuleucel LT immunotherapy currently is only approved in metastatic castration-resistant prostate cancer. Right now, it's actually being studied in other settings, particularly in low-risk disease for men on active surveillance. But as of now, that's the only space where it is approved.
Thank you for clarifying that. From Joel, we have, is there any data on the long-term survival of patients on immunotherapy beyond the 18 months?
Well, that's the 18 months is the improvement compared to placebo. So men with metastatic castration-resistant prostate cancer have an average survival in the 2 to 3 year range. And then any treatment that is given has to be able to add a significant amount of time to that. Men with metastatic hormone sensitive disease, it's somewhere in the 6 to 7 year range. And then men with biochemical recurrence with no evidence of metastasis, that can be, anywhere from 8 to 10 years, depending on what their PSA is doing. So we do know the average lifespan. Those are all averages. I've had men who live much longer with metastatic castration resistant, and I've had men who progress very rapidly, who have very aggressive disease, who didn't last a year. So it really depends on how people respond to the therapies that they have available.
That makes sense. And then one final question before we hear from Robert Ginyard, our next speaker. Is there financial help available to get the immunotherapy?
Yes. So there are foundations, and Zero has helped people in finding that. The company itself that makes Sipuleucel T does have some funding to help patients, particularly with the travel costs that is associated with it. It is covered by Medicare, and therefore is covered by private insurance. For someone who's completely uninsured, that would have to be either given at a much discounted rate or free according to the institution, or would be provided by the company. So you would have to search for some resources, but if your physician offers that, then that's one of the areas that you can work with them to try to get assistance with the cost, because it is expensive therapy.
Thank you so much. And now we are going to turn things over to Robert Ginyard and hear a little bit from the patient perspective, and then we'll have an opportunity to ask some final questions afterwards. And Robert, we can see you on camera.
Hi, good evening, everyone. I hope this message and this talk finds you in good health and great spirits. My name is Robert Ginyard, as you see, and I am a prostate cancer survivor, as well as the chair of the board of directors for Zero, the End of Prostate Cancer. I want to thank Dr. Moses for his information that he was sharing. He and I do some of the seminars at the Zero Summit each year, where we talk about this subject. So I'm always have it a pleasure to be with Dr. Moses and be in his company. So to borrow a phrase from another prostate cancer survivor, Phil Shulker, I'll say this: Dr. Moses is so talented and has a depth of information on telling you what cancer is. I can tell you as a survivor what it's like, and that's what I plan to do in this presentation here. So I was diagnosed with prostate cancer at age 48 in 2010, and it was discovered through my annual checkup with my general physician. And I've got to say this: my physician had been following me for years, and he really kept an eye out for my PSA numbers. He did see a gradual increase in the numbers over a period of years, and so I'm grateful for him for just keeping an eye on that. And really that helped me come to the conclusion of, like, at this point, once my PSA level reached a certain level, my doctor then said, hey, look, okay, I think we're at this point now where we need to have you go see a urologist. And then that's when I went to get my biopsy done. And sure enough, about 3 or 4 days later after the biopsy, it was discovered that I did in fact have prostate cancer. Now, I'll also share this, and some of this I'll talk about later on in the presentation, is that my father also had a bout of prostate cancer. And for many years, the family didn't know it because he had asked my mother to promise not to tell the kids because he didn't want us worrying about it. And so you may be saying, how could someone do that? Let me just tell you, it happens frequently. And that gets it back into that male ego of ours, that we think we can handle this and we'll tackle the issue on our own. But I did talk with many other prostate cancer survivors, and they too said that their parents or their father or brothers held the information from other people without telling them. So, and we'll talk about this later on in the slides, but that's something that happens frequently. And I think, particularly in the African-American community, that's something that we'll have to address in terms of having that discussion about our health. So the real talk about prostate cancer is location, location, location. I remember when I worked in the real estate industry years ago, that was key, location, location, location. And it applies to men and the way they view their bodies. For most men, anything or any thought of anybody doing anything below their waistline is a barrier. And so when we're out trying to get men to talk about prostate cancer and prostate cancer screening, one of the things that they typically have a hard time dealing with is the digital rectal exam. As a matter of fact, I remember years ago, I was on a talk show, and this caller called in, and we were talking about prostate cancer in the screening process, and he told me flat out that he didn't want to go get his prostate cancer or prostate checked because he didn't want a doctor inserting his finger in his rear end. And so, you know, and quite frankly, that's not shocking. I still hear that, you know, in terms of screening. So we still haven't gotten away from that. And then additionally, when you're talking about any kind of procedures that may be done, most men figure that, okay, if I get treated for prostate cancer right away, it's going to be an issue with erectile dysfunction and problems with intimacy. And some men elect to hold out as long as they can because they don't want anything to tamper with their manhood. And so, again, that's something that's very prevalent. I talk to men day in and day out, and they share some of the stories and some of the reasons why they don't go to the doctor. And, you know, I'm still surprised that that still comes up a lot because it's how will I please my significant other or my wife, you know, so we still have to deal with that. And then there's the belief that most men will die with prostate cancer than from it. And so sometimes I get waved off from men when I talk to them about screening. And, you know, it's kind of a common belief that, oh, you know, I heard that I'll die with prostate cancer than from it. And so, again, those are contributing factors that's keeping men from going to the doctors. And then the other talk about prostate cancer is that it's very personal for men. And there are a lot of men who were treated for prostate cancer and they don't tell anybody. You know, I don't know, they look at it as if it's this scar, this scarlet letter. And so they hold back information. They don't tell others about what they experience and how to combat the disease or, you know, the importance of getting checked. And I really would want these, I call them silent survivors, to speak up a little bit more because they can provide valuable information that could lead to advances in future treatments for the disease. And I'll address this in another slide, but when it gets again to the prostate cancer is personal, I recall when I was first diagnosed, I was in search of what were the statistics for African Americans who were going to go through the treatment that I was going to go through. I went through a radical prostatectomy, followed by hormone therapy and radiation treatment. But I wanted to find out from other African American men how many people had gone through that regimen of treatment and how it affected them. And quite frankly, the numbers weren't significant to give me some kind of solid background as to how to pick my treatment. I did eventually go through those 3 treatments, but again, that's why it's important that as African American men, we talk about this disease, where clinical trials are available, that we participate in them so that we can leave a legacy of information for the next generation who may come in contact with this disease. So the role of trust. I just mentioned about clinical trials, but when it comes to health disparities in treatment, Black men, we still have some trust issues. And a lot of times when I'm out screening, working with screening crews or talking to men in general, the Tuskegee study is still front and center in the minds of many Black men. And that is why they do not want to participate in anything. I also hear that the government is involved, and so they want nothing to do with it. We are starting to chip away at that a little bit, but while this has been many years since the end of the Tuskegee study, it's still fresh on the minds of a lot of men. And then you also have the case of Henrietta Lacks, who unknowingly donated herself to Johns Hopkins in 1951. So you have a study that features Black men, but then you also have the study for women. And so those are two of the main reasons that most Black men still are very hesitant in terms of participating in any kind of study. So for clinical trials, one of the things that I've been recommending, and from information that I've received from many of the prostate cancer survivors, is in order to raise the participation rate for clinical trials, African American men want to know the answers to these questions. Who are the researchers? Why is this research being conducted? What will the research be used for, and who will benefit? And what systems are in place to ensure that there are no hidden agendas behind the research? And again, a lot of this has been anecdotal that's come to me, but a lot of Black men are like, what's going to happen with this? Am I going to be used as a guinea pig? Who's conducting the research, and what are they doing it for? So again, Tuskegee and Henrietta Lacks, they are, because of what happened with those two individuals, that's how it's impacting the clinical trials and the research. And so Dr. Moses brought up some of the other factors that play a role in Black men and prostate cancer. And I would say that these three items here, in terms of the stress of being Black in America, there is the additional stress of being an African American man in America, because there's always that X factor. And when I look at some of the data that talks about, Black men are actually it's 2.4 times more likely to die from prostate cancer. And the research is out there, and it says, okay, you have a Black man, white man, and here are the tests that we are studying. But what is that X factor that is causing more Black men to die from the disease? And so there are some other social determinants, as Dr. Moses indicated. But there's this general stress about being African American in America. I'm not immune to it. Every morning that I wake up, I have to worry about what's going to happen to me on the road. What if a police officer has a bad day? I'm dressed suit and tie, but it may not make a difference. So in the back of a lot of African American men's mind, that's what they're thinking about. We're on 24/7. And I used an example several weeks ago. I was talking with a class and indicated that I could go to a department store, and a white man and me as a Black man, we both buy 2 hoodies. Now, the white man can put that hoodie over his head, and as I'm making a decision to buy this hoodie, I've got to worry about, okay, it looks good with the hoodie down, but what happens should I put that hoodie up? And so, and there are plenty of examples of that stress that's every day, and how that impacts your health outcomes. So I think that is that X factor that contributes to it. And then also the circle of influence. Does the African American man's circle of family and friends support a healthy lifestyle? You are your network, basically. And so in some of the communities that I've had the opportunity to work in terms of prostate cancer screening, we look at, some African American men they're looking at, okay, how do I make it from day to day? And if my friends are suffering, low economic outcomes, How is all of that contributing to my ability to eat healthy? Dr. Moses brought up the food deserts. And so in a lot of communities, who else can contribute to a healthy lifestyle? Are there grocery stores close by that can serve the vegetables and the proper foods that can help you live a healthy lifestyle? So if you're around a circle of other men who are not healthy, chances are you're not going to be healthy. So circles of influence in your network is important. And then place matters. Again, Dr. Moses brought this up, but the physical condition of neighborhoods has a difference, and it has an effect on your health outcomes. If you're in a neighborhood that has a lot of abandoned homes and there's trash and debris in the neighborhood, that has a way of playing into your psyche. So, we have to take those matters into consideration in terms of why Black men are getting this disease and why they're dying from it. So how do we narrow the gap? Now, Zero has put together a new task force to eliminate disparities in prostate cancer. And so we're bringing a coalition of people who have expertise in various areas to share their experience and look at some of these reasons why men are suffering from this disease and why is it this gap and how do we close it? Secondly, we have to have the health is wealth conversation. So poor health limits your possibilities of economic improvement to create wealth. If you're not healthy, chances are you can't work or it limits your ability to work. And so we really have to value health as that engine that gets us to create economic improvement and to create wealth. And then encourage African-American men to take ownership of their health outcomes. You are responsible for you. I know in the case of, for example, my family is all to me. So I want to be around long enough to watch them grow up, watch them finish college, be with my wife, walk on the beach and have wonderful sunsets together. So we have to encourage men to take ownership of their health outcomes so that they can be around for their families and friends and other members. And then again, it gets back to encourage participation in clinical trials. And again, in order to do that, men have to be comfortable with the questions that I had posed on the previous screen. And so with those questions being answered, I think that will play a huge role in terms of getting Black men to enroll in the studies. And then I would leave you with this. It's a poem I wrote because it all gets back to how you value your life. And if good health is important, you will treat it as such. So if I knew better, I would do better. If I do better, I would live better. If I live better, I would love better. And if I love better, I might just live longer and better. So again, this gets back to taking ownership of your health outcome and bridging that gap again with disparities. So I'm confident we will get through this. We just have to give more men the reason why to live. And if we give them the why, we'll find out the way. So thank you for allowing me to share a couple of words with you, and I'll take any questions, Colleen.
Thank you so much, Robert. Always inspiring. We do have a few questions, and I just want to tell the group who's viewing today, thank you for your patience in getting us started. And we are going to go a little bit over because we've got some great questions that I think we can all benefit from. So one for you, Robert. Sanford is asking, did you join a support group prior to treatment? How has support groups played a role in your journey?
Well, to answer your question, no, I did not join a support group prior. I did make several calls to some prostate cancer survivors, and actually my physician had given me permission, had gotten permission from some of his patients for me to reach out to them. But no, I did not join a support group prior, but I sure as heck participated in many support groups afterwards to help be that voice or that calming voice that says, hey, we can get through this. And again, I think that support is needed, particularly afterwards, because a lot of men think it's downhill afterwards, and there's a strong network of support out there. So I try to make sure that I'm strongly engaged in supporting other men.
And I think this question, Dr. Moses, if you want to turn your camera back on, this really could be for both of you. From Erica, what is the #1 thing you wish Black men knew about prostate cancer? What's a good takeaway for today? And this is for both of you, Robert, so feel free to jump
Well,
in.
I would say that the important thing is I call it the silent killer, because a lot of times you don't know the severity of it until you start having symptoms, and so that's why it's important for me to tell other men to make sure that they get screened, and so that would be my suggestion to Black men. But again, in my opinion, if your health matters, you're going to make sure that everything gets checked. And so, but yeah, because of how deadly this disease can be, that's why I really stress about early detection.
And to follow that up, there was a question about, is there a recommendation that Black men get tested? What age? Is that different from white men for prostate cancer?
Yeah, so if you look at all of the various health societies that make recommendations on screening, so that's United States Preventive Services Task Force, American Cancer Society, National Comprehensive Cancer Network. In general, they say start around 50 or 55 if you're in reasonable health and want to learn more about prostate cancer screening. Some of those guidelines panels do make exception for Black men and for men with a first-degree relative for prostate cancer to start earlier. What I have recommended for Black men is to start at 45, knowing that Black men do tend to develop prostate cancer earlier. And if there's a family history, even starting at 40, even if it's just to get a baseline. So I would say, pay attention to what the guidelines say, but also understand that Black men do have this risk of earlier disease. So I would say starting at 40 to 45, at least to get that baseline, but certainly start getting annual PSAs by 50 to 55.
And a follow-up to that, Dr. Moses, and for Robert, from Carol on our Facebook. She says, please tell us how to convince a loved one to get screened. What keywords when talking to our Black men can we tell them this is a must?
I'll let you lead with that one, Dr. Moses.
I would say, look, do you love me?
Yeah.
Do you love yourself? What are you afraid? What are you afraid of? Let's talk about it. Let's get through this. And I'm assuming this was a woman, and if you're of a certain age, if you've gotten mammograms or pap smears or whatever, just say, hey, look, I do this to take care of my health because I care about myself and I care about you. And this is something that I think you should do too for the both of us.
I have a suggestion, and I think this is such an endearing way to put it. Just say, wouldn't you like to spend an eternity together? And let's live our life together for a long time. And typically, the man will go to the doctor. So we have to charm him a little bit to get him there, but we can.
I love it. Yes. This has come up, a question has come up several times about physician bias, and does that play a role in how Black men are treated for prostate cancer?
It is, and that's why I emphasized make sure you're asking questions of your physician, make sure they take the time that you need. Obviously, if you can find an African-American urologist who can sympathize not only with your disease process, but your station in life in this country, then all the better. My job as an academic urologist is to try to diversify urology. It's a relatively homogeneous field. And so I'm trying to recruit more and more Black men and women into urology because it has been shown multiple times. Black patients have higher rates of satisfaction, and better outcomes with African American physicians. Same with Hispanic patients. Conversely, white patients have similar satisfaction and outcomes regardless of the ethnic background of the physician. And so what is built into that is the trust factor. When I walk into a room and there's an older Black man or older Black woman sitting there, I can see their face relax because they were not expecting to see me walk through the door. So again, if you don't have that option, if your only physician it does not look like you, just sit down and say, look, I need you to understand where I'm coming from. These are my questions. Let's take the time to do that. And if I need to come back or wait till the end of the day or discuss over the phone, let's do that, because I want to make the right decisions for myself.
And Robert, I'm going to give you the last word as we're going to be wrapping up. Oh, go ahead.
Dr. Moses said, when it talks about trust, trust is built over a period of time. And one of the things that's important for men to have a doctor and begin the relationship, because a lot of times, some men who don't have a relationship with a physician, they're having some symptoms, and the next thing you know, they see a doctor and they're being told that, hey, you have prostate cancer, and it's this rushed at this point because you're dealing with the cancer, but then you're dealing with the relationship with a doctor and these people that you don't know. So I would say as soon as possible to continue to have those conversations with the doctor. But if you don't have a primary physician, find one, begin that relationship so you can have these conversations, and the trust factor is there. But when it's down to the wire and you've just been diagnosed and you really don't have a primary care physician, everything is new to you. So therefore your trust level is not as high because you feel like you're being bombarded with all of this new information. So I think, as Dr. Moses pointed out, it really gets back to that trust factor and having someone that you have a relationship with to guide you through the process.
Well, thank you all very much. Thank you to Robert. Thank you to Dr. Moses, and of course our sponsor Dendreon for this informative presentation and discussion. And it certainly doesn't end here. We're going to be continuing this discussion. You can go to our website and read some great blogs that both Dr. Moses and Robert have come together on. And I know they'll be authoring some more things, and we're excited to be rolling out our new task force that Robert mentioned that is going to be co-chaired by both Robert and Dr. Moses. To close out the webinar today, I do want to highlight a couple of our zero patient support programs. It's especially important during COVID-19 pandemic for all of you and other patients and caregivers to hear you are not alone in your fight. Zero is here with you. And we had several questions that we didn't get to today, but were really more about what support is out there for me as a patient. And so this is actually the perfect ending. With the increase in unemployment rates, the loss of healthcare due to COVID, and other challenges and barriers that patients are facing, 0360 has become a lifeline for patients. And 0360 is Zero's comprehensive patient navigation service that provides individualized case management to help patients and their families connect with financial assistance. We got some questions about how affordable some treatments are, to navigate insurance, what if something is getting appealed, what do I do? And find other kinds of support, including free transportation. We saw that transportation can be a huge barrier for patients. All you need to do to get started with 0360 Case Manager is to call the toll-free number, which is available on our website. And they are open 5 days a week. We also talked a lot about screening. Screening is critical even during a pandemic. We obviously want you to do it safely. And for those who are interested in getting tested for prostate cancer but are concerned about associated costs, you can also visit our website to view a nationwide database of sites that have indicated that they provide free or low-cost screening. Because of COVID, obviously it caused some changes for sites. Some of them have been updating their offerings, so we do encourage you to call the test site first to make sure you're aware of whatever safety recommendations and new protocols that they may have in place. Another really important question that we got today was about support, support groups, one-on-one support. In this time of COVID, it's kind of been the perfect storm. Many patients and caregivers don't have access to their regular support systems. We certainly understand how important it is to talk to another patient or caregiver who's walked in similar shoes. That's why not only did we want you to hear from a medical professional today, but we wanted you to hear how it's like to be a patient. We know how important that is. And Zero's peer-to-peer support programs, Robert's been a wonderful mentor for us. We now have a program for caregivers. We match patients and caregivers so that they can have somebody that they can really connect with. And as you can imagine, during this time, it's really been needed. And we've got some beautiful, heartfelt messages from those who have really benefited from having someone to talk to during these difficult times. So please know that those programs are available to you. And then finally, if you want to access a passionate and supportive community right from your fingertips, you don't have to physically go anywhere. Zero Connect is our online private Facebook support group. There are many others across the United States who've been affected by prostate cancer, and they're there to help learn from each other's experiences, ask questions from patients and loved ones across the country. The group is now up over 2,500 members, which means any time a day, anytime you go there, there is a lot of support and encouragement for you. So I hope that those of you who are already on Facebook will join us and be part of that group. We would love to have your voice added to that. Lastly, I want to make sure that you all know that all of the programs that we just talked about are at no cost to patients and families. So if you are struggling or you know somebody who's struggling with prostate cancer, please share these and let them know that we are here to help. And more information is available on our website, and that's at zerocancer.org. So we encourage you to visit it. And lastly, this is the conclusion of tonight's webinar. Also on our website will be a link to the recording. We did get a few questions on, can these materials be shared with others in my community, with my medical team, whatever makes the most sense. It is there for you. Please share it, use it as you need. And then lastly, we will be asking for your feedback and would love to hear from you about what you thought of tonight's webinar. Thank you all for joining us. I hope you have a wonderful evening and stay safe. Good night.